appreciate each and every one of you being here tonight. I think I know everyone in the room, but in case I'm Sherry Sidley, I'm the CEO and President of Lakeland Community Hospital and a long-standing community member here in Haleyville and Bear Creek. So tonight we have some really interesting information we would like to share with you. Each year, as part of the Healthcare Authority, we like to present to you information about the hospital. We call it State of Healthcare. Very similar to what the educators do, I think on an every 3-year basis, which is State of Education. And it is where we are as a healthcare entity at Lakeland Community Hospital. Before I get started though, I have several things. Thank you to our employees, our directors, our physicians, providers for being here tonight, for your incredible support. We appreciate Congressman Adderholt having Will here tonight. Thank you so much. And all of our county and city officials. Thank you for taking time out of your evening. Also, to expedite your meeting tonight so that you could be here. It's much appreciated. So we have 4 speakers tonight. I promise we will not take longer than 5 hours. And all of these speakers come with an incredible amount of experience. So myself and Wes are our current Lakeland Community Hospital leaders. And with us we have 2 special guests. First we have Dane Howard from the Alabama Hospital Association. Dane has been with the Hospital Association for decades. She has experience not only in management of the Hospital Association, but emergency preparedness, operations, governance, and much more. She may have the biggest job in the room as she herds 100+ hospitals every day as we have multiple needs and requests from her. We also have Toby Butler with us. Toby is from Trilogy Healthcare Solutions. He's a managing partner. He, along with many others, has decades of experience, not in healthcare, but in rural healthcare, in both, really. He has managed hospitals out of crises. He has helped with physician practices, and he is also our consultant here at Lakeland as we've gone through the critical access journey. So let's get started with our history. Many of you know this, but it's always good to get a refresher. So our hospital was built by the Healthcare Authority in 1969. Now how many of you are younger than 1969? So it's interesting, I was one of the last babies born in the Wilson Hospital. So a little history for you. We used to have many hospitals in this community. We had the Wilson Hospital, the Blake Hospital, the Wood Hospital. And part of the Hill-Burton Act was to pull all these little hospitals together into one. There was a grant given, and in 1969, the hospital opened and saw its first patients. Now, fast forward, 2026, here we are today. We are now a critical access hospital, and we are here as 1969, taking care of our community. We are 200+ employees, 200+ or minus employees. We are one of the largest community county businesses. And we have some of the highest wages in the community. And why is that? Are we overpaying our staff? Those that are sitting over here would say absolutely not. But we have some of the highest wages due to the education required from a lot of the physicians. So tonight we're going to go down 4 paths, and that is the 4 things that hospitals across the country, ours specifically, provide. And that's quality, service, community, and then operations. So let's start with quality. It's important if we have a hospital in our community that it provides good quality care. Now, as I said, our hospital has been around 58 years. So I'm sure that every person in this room has a story about Lakeland or Burdick West or Caraway Burdick West. And I'm sure a lot of them are positive and some could have some improvements. Any business that's been around that long will have positives and negatives. It is important, though, that we have more positives and negatives, and we make those negatives right. One thing that Medicare does, who's one of our governing entities, CMS, is they score us. Not just us, but every hospital. This is done equally across the country with every hospital, and they give us stars. Kind of like the Google stars that you may get when you give someone a review. And so as of today, we are a 4-star CMS hospital on a 5-star level. Now, those scores are ranked with cost of care, service, satisfaction, and then there's an algorithm that is fed through that to determine your score. So we are a 4-star, we're very proud of that. Our peer hospitals also get ranked, and our sister hospital, Winfield, is also a 4-star hospital. Now, we have other hospitals, Russellville, a 2-star, Fayette, a 2-star, and AMC, a 2-star. And I'm not saying they aren't doing a great job, I'm just saying we are all judged and ranked equally based on the criteria, and we're very proud of where we are today, and we only want to get better. So you think, okay, you're a 4-star, that means you've got some improvement, right, to get to a 5. And that's absolutely correct. The biggest area of opportunity that we have is in communication. And we have a lot of work that we're doing there. Communication about your medicines, communication to patients about their discharge. Those are things that we focus on today. So next is community. As a community hospital, it's important that we support our community. And how do we do that? So very proud this past year, we started our first annual junior volunteer program. And this was a program where high school students all through the county and in Bear Creek participated in a 40-hour volunteer program, and they got to work in all the different departments of the hospital. It was a great area of opportunity for them. They got to share their experiences, and I'm happy to say that all of those high school students either are in a healthcare program or plan to be in a healthcare program as they continue their journey in education. We also provided a tremendous number of health classes. We had over 300 participants last year alone, community employees who went through CPR, advanced CPR, PALS, NOWS, all those certifications that you need to be part of a hospital. Last year we did hands-on CPR at the 911 Festival, which is a very quick 5-minute drill on how to do CPR if someone is not breathing. And we provided that to hundreds of people, and we're going to expand that this year to other festivals as well. We also do clinical sites for nursing, EMS students, laboratory, radiology students, just to name a few, as they rotate through our hospital and learn about healthcare. We're involved in our community through Rotary. We have several Rotarians on our hospital director list. We have BPW, Civitans, Chamber of Commerce. We participate in backpack programs and really any program that's going on in the city. If we hear there's a need, Toys for Kids, the gathering place, then we're there and we provide assistance. We also have a foundation. The Lakeland Community Hospital Foundation has been in place for several years, and we have many of those members here tonight. Last year alone, we provided $8,000 worth of scholarships, 8 $1,000 scholarships to every Winston County and Bear Creek High School senior who are going into healthcare. We also keep up with them to make sure that if they have any issues, if they need any assistance. We had one young lady last year actually flip a career from an accountant to, bankers, she flipped to healthcare. But we helped her assist in that so that she could get into the right school and get her degree as needed. So let's talk about services. What does Lakeland have to offer? Many of you think, I've been here, Sherry, I know what you have to offer, but it's always good to have a refresher. I also want to rewind. In 2024, the Healthcare Authority, and thank you board members for being here tonight, sat down and we decided that we needed to get some community input on what's really important to the community about our hospital. So we pulled together a business development group of local leaders, some of them are here tonight, and we asked them to deploy to the business community in Winston County and ask 3 questions. Do you need a hospital? Is this hospital needed? Do you find it beneficial? What could we improve upon? And will you use this in the future? We took all that information, we aggregated that data, we sat down and we looked at what are we offering and what is required or needed for our community. And many of those things we are providing today, or we have started providing, but the number one thing that stood out in those conversations was that healthcare is important. If you are 40 years old, you may not see the value of a hospital, because at that point, you really probably don't have a lot of need. You need a physician, you need an urgent care, you need the ability to get services that you need at that moment, and services for your children. When you're 60 years old, you have a different need. You're taking care of aging parents. They need a local hospital that they can be admitted to. When you're 80 years old, you're that person that needs someone. and driving 45, 60, 90 miles to get that care is a tremendous burden on families, patients, and like. So yes, the hospital was important. It was also important to have a 24/7 emergency room that was consistent 98% of the time, to have a doctor available if I have an emergency and I really need care. So here are some of the services that we offer, either continual or have added. One is our swing bed program. No, we don't attach anyone to a swing and move them around. It's a 21-day rehab program for people who may need a little extra help getting to the next level after a surgery, after a major illness, a major diagnosis. We have inpatient care. If you need inpatient care, we provide that. We also have, as I said, a 24/7 staffed emergency room. We just opened last week, Jan, raise your hand, Debbie, our intensive outpatient program, which is a program for all of Winston County. We have a bus that will be going to all Winston County and parts of Marion and Franklin, bringing seniors over the age of 65, Medicare recipients, that may need a little help getting to that next level from depression, anxiety, coping skills, and we have had a large number of patients that we are screening, so thank you to Jan and Debbie for that work. Access to more health clinics. We have 2 rural health clinics, Dr. Johnston, Ray McCandless, both are here today, and expanding that in our rural community. Advanced imaging, MRI was the #1. We brought MRI services to our community last year, and we have plans to even expand that further, along with things that you expect, laboratories, cardiology, cardiopulmonary, those type services. So part of our work every year is to do a strategic plan. The board, Healthcare Authority, takes that very serious, and we look at data. We have a lot of data points that we get from the Hospital Association and others to determine what is the need for our community, and our data points that in the right direction. So we always start with quality. It's so important first that you provide good care. Becoming a 5-star CMS hospital is important to us. So we have a lot of things in place already to get from that 4 to 5. We've had a 5 before, and we can do it again. As I mentioned, having 5-day-a-week MRI services, another x-ray that is so important as you're trying to determine what needs you may have. And we're also evaluating surgery. That's something that came up on our BDR visits. And as you think about the seniors in this community, which make up over 60% of our population, having ophthalmology and endoscopy care here locally is important. So that is also something we're evaluating. Other things that we look at is renovations to our emergency department. Expanding our rural health clinics in areas that may not have care. We can do that in many ways, one through telehealth, one through our extenders, and expanding telehealth, not only stroke, but psychiatric care and cardiology care. And then thanks to David Cummins, our commissioner and chairman, he pointed us in the right direction to get some VA services, and we are, as of this week, a VA community network, so our veterans will be able to stay home and get care, which is much needed, opposed to having to drive to Birmingham, Tuscaloosa, and other places. From an operations standpoint, we've talked about a lot of this, and that's having an adult program. Adult volunteers, we've had so many seniors ask if they could come and help. And we had that before. You may have heard them called candy stripers. But as part of Hospital Week in May, we'll be rolling out the process to become an adult volunteer, and we expect to have a tremendous number of volunteers to come out and help serve in our hospital. Also, a successful critical access transition is imperative. Many of you have heard us talk about it. We started that education last year, our board, our leaders, and that is the future of our hospital. To be a sustainable hospital here, the path we were going with acute care was not going to be sustainable. So we quickly met with state officials to determine if we met the criteria for a critical access designation. And what does that mean? Critical access means that we get paid in a different way. So we get paid to be in a rural community. We get paid to do our care in cost versus contract, is how I like to say it. Wes always cleans that up. But we do have the path to do that and to be a financially stable institution. The last thing I want to do, Wes wants to do, our leaders, is to be a burden on our community. That's not what a hospital should be. We also don't want to be a continual struggle hospital. We want to thrive, not survive. And that's where we have a path today as we move forward. As we think about strategy, another opportunity we have is grants. We have tremendous work with NACOG who are helping us identify grant opportunities throughout our hospital, things that we can do for renovations, repairs, expansions, improvements in our operations. And this is just one example. This, while it's some maybe a little eyesore for you, but it's how to become a community anchor model, how to become that hub in rural America, so that as we continue to build upon our clinics here locally, we can also receive grants to have an expanded telehealth presence, so anybody here in our community can have access to those specialists, such as cardiology, psychiatry. Those are so important as we continue, because a lot of when you look at our demographics in Winston County, there's a tremendous number of our elderly that are unable to drive to those specialists. So this is an opportunity for us to bring those specialists to them. I would now like to introduce you to Dane Howard. I mentioned her before, but Dane is our president of Alabama Hospital Association. And we're going to pivot our conversation now from what does the hospital do and provide to the economic driver that a hospital does for a community. So Dane?
I apologize for making you be a few minutes late kicking off. I was tied up in the legislature for a few minutes and they kept me longer than I wanted to be over there, and then navigating traffic through Birmingham is never fun on either direction these days. Real quick, just a couple of things about me and about the association. I have been with the Alabama Hospital Association for 30 years. Prior to that, I managed a multi-physician practice in scrotum surgery for nearly 10 years. Big jump from the clinical side to the political side, but I have represented every hospital in the state of Alabama for nearly 30 years, well, for 30 years, both in Congress, with CMS, in the Alabama legislature, and with all the regulatory authorities that work in and regulate everything that hospitals do. I have well, I'm a lobbyist, or have been a lobbyist, and I'm still a registered lobbyist, and a lot of people think that's a bad word. And a lot of people think these special interests run the day. That's not our job. Our job is to educate our lawmakers on impactful decisions that they're going to make and what it means to the communities that they represent. We never go in, at least the Hospital Association does not go into Congress to meet with Congressman Adderholt, to meet with anyone in the Alabama legislature without giving the full story. We don't try to coerce, we give facts and information, because if we don't give the right information and they make decisions based on inaccurate misinformation, do you think they'll ever come to us again and ask? No. So we try to uphold at all times, so both sides of every story. The Alabama Hospital Association is a trade association representing every hospital in the state. There are 126 hospitals in the state of Alabama, both psychiatric hospitals, rehab hospitals, and full-service acute care hospitals, critical access, and now we have rural emergency hospitals, thanks to an innovative program that Congress passed several years ago. I always hate to go down the path that I'm about to have to go down. I'm known for bringing a lot of doom and gloom. There are a lot of challenges for rural health care. As a matter of fact, we are really excited, not because of the challenges, but we are for the challenges. We're seeing the challenges as opportunities, right? There is opportunity in every challenge if you try to look at it the right way. What we're excited about is, for the last couple of years, there's finally focus on rural health care. There's not been as much focus for a really long time. Now, I have addressed both caucuses in the Alabama legislature and a number of groups over the last couple of years. And the speech that I give, and as you notice, I don't have notes, I don't use PowerPoints, I just run my mouth. But the speech that I gave when a lot of this focus shifted to rural health care was, see, we told you so. You're now saying everything we've been saying to you about the importance of having a viable and strong rural healthcare delivery system. It matters to everyone. It matters to the urban areas. It matters to you. I am a rural girl. I was born in Demopolis, Alabama, at Brian Whitfield Hospital, now known as Whitfield Regional. grew up in Pitlala, Alabama, if you've ever heard of that. It's a little rural area about 30 minutes outside of Montgomery. I can appreciate the challenges, I can appreciate the struggles. We're on both sides of the aisle and representing all of the hospitals. But let me tell you why it matters, and then we'll get to the economics, I promise. If rural community hospitals are not here and not able to provide the care that they can provide to your communities, the urban hospitals in the larger areas, the tertiary hospitals, they cannot absorb the volume. They don't have capacity, nor do they have staff to take care of everything that your rural hospitals do on top of providing the tertiary care. When a hospital closes in a rural area, and it has happened, the last hospital that closed was Pickens County Hospital. Thomasville Hospital was shortly after that, another critical access hospital in southwest Alabama. When a rural hospital closes, you lose much more than just access to that hospital. You lose the economic driver in that community. If you had to go to a community 3-4 community counties over, you had to go to Huntsville for all of your care, you had to go somewhere else, you're probably going to pick up your prescriptions while you're there. And you might go shopping for your groceries while you're there. And you might decide that you want to shop for your children's school supplies or school clothes while you're there. You just took a lot of economic development out of your own community. No fault of anyone's, it's just the natural course of how things happen. It's hard enough to recruit physicians into rural areas. I'm not sure where you are, but you pointed to some doctors out here who can testify. It's hard to recruit physicians to rural areas, and there's a lot of reasons, especially in Alabama. Part of the reason is we have one of the highest uninsured rates, particularly in rural Alabama, in the nation. We are the lowest reimbursed hospitals in the nation for providing the exact same type of care to the exact same type of patient in the exact same type of facility. Part of that is Medicare. Congressman Adderholt has been one of our champions as we're working to try to address that in Congress, and it's not an easy lift. We're fighting against California, New York, Massachusetts, and I can go on and on. It's not a friendly fight. We're the lowest reimbursed commercially. Blue Cross Blue Shield and all the other commercial insurers, our data, which we collect, indicates and shows clearly that we are significantly paid less for providing the same care as other hospitals in our border states. I can't answer all the questions why, but it's true. Our physicians are some of the lowest reimbursed physicians in the nation. Our hospitals certainly are so. So those are just some of the challenges in trying to recruit and retain medical professionals in our communities, which we're standing here promoting and saying and want to make our hospitals as strong and viable and our whole healthcare community as strong as they can be. Once upon a time, hospitals were really about the four walls. It was where you go to get care, where you go to have surgery, where you go when you're really sick. Our hospitals now are so much more than the four walls, as you, I'm sure, are aware of. It's about the community engagement. It's about wellness programs. It's about keeping people out of the hospital. All of those things take resources. All of those things take money. All of those things take our ability to pay competitive salaries to our professionals. Health careers is a #1 focus of our Alabama Hospital Association. There are two major struggles of every hospital in the state right now. Primarily, or just harder on the rural hospitals, and that's the systemic problem that I just mentioned in the reimbursement rates. Our costs are not significantly lower than other providers in other states. Our reimbursement should not be significantly lower. When we're trying to provide the quality care that we need, we have hospitals across the state having to make hard decisions. I was actually in southwest Alabama on Friday doing a very similar discussion like this. Unfortunately, they've got some more dire circumstances there in a couple of rural hospitals in a vast healthcare desert in southwest Alabama. We're working hard every day to try to figure out solutions, to try to figure out what can we do. One thing that I will say, our association appointed a task force in 2019 that task force, we called it a future directions. Our direction that we were investigating was rural health care. What do we need to do? What do we need to look at? Do we need to look at things differently? Where are the resources now, and where are the gaps, and what can we do? And then COVID hit, and a lot of things had to be put on pause. All of the problems that existed in 2019 are still present, but they're exacerbated, they're worse. Our healthcare professionals, we have a larger workforce shortage than we ever have. We don't have, or we haven't had, a strong pipeline being built for professionals in any of the health careers to step in for some who retired and some who just decided that COVID was more than they could take, so they left. Before we can get there, though, we have to determine what do we need to do. That task force that I just mentioned, we just reappointed another one a year ago. We're working right now on a landscape assessment. And when I say a landscape assessment, it's provider services. We know where all our hospitals are. I know what all the service lines that every hospital in the state of Alabama provides. What I don't know is where is every diagnostic center? Where is every oncologist? Where is every mental health professional? Where are all the other things? So we've mapped most of that out now. We have an interactive map that we're using and we will be using to help drive some decisions, I hope, with the Rural Transformation Program. That was included in the big beautiful bill. Heretofore, I will refer to it as HR 1 just because it's not as many words. We're also working with our task force to identify some things that we can do as hospitals outside of that would complement some of the rural transformation. What I will say to you is that the rural transformation money that Alabama was awarded, which is $203 million for the first year, it's a 5-year program. Unfortunately, the way the bill is written and the guidance that we've received from CMS, hospitals aren't going to get that money. It's not like every hospital is going to get a check. I don't really have all of the clear picture yet. We're still waiting for exactly how all of this process is going to work. But there's a very large misunderstanding in public that this money is going to be sent to rural hospitals. Well, it's not. It is going to be, and it is going to, or is intended to finance seed money for some programs to provide assistance for rural hospitals, such as rural health, transformation in telehealth, in mobile units for mammography in areas where there's not. There are hospitals, there's Demopolis is the only mammogram in 100 miles away. 100 miles circumference, and we have citizens who don't have the ability to drive. A lot of the programs that we believe that the transformation money are going to fund are going to be things like that. But now, there are so many other things, community paramedicine for one. There's so many other initiatives that we're doing a deep dive on, hopefully that don't require state resources and state funding. Are you aware of the Rural Hospital Investment Program that we passed, the legislature passed last year? This was the first year that it became available. If you haven't heard about it, I know your hospitals will be happy to tell you about it. It is a program that we emulated from Georgia, where every hospital has an opportunity to get contributions or donations from businesses, foundations, individuals, and for the contribution and donation that is given, you're the dollar-for-dollar tax credit for Alabama's taxes. It's capped at $20 million the first year. We busted the cap in less than a month. We have one hospital who met their cap in 15 minutes. What did that say? That said our communities support our rural hospitals. Our communities understand, and we want to make sure they continue to understand the importance of rural hospitals. You have a gym. You have a gym in your hospital, and you have a gym in its leadership. It's our job, it's my job, to make sure that we're prepared to respond. And I can talk all day. My dad used to tell me, you will make the living, run in your mouth and argue with people, and dig down if you wasn't right. I don't like to stand here and just chat about it unless I'm telling you things that are helpful, telling you things that you want to know, telling you things that you want to hear. Am I telling you that 84% of Alabama's rural hospitals have negative operating margin is not exciting? That's bad news. It's been that way for quite some time. To tell you that there are some very dedicated people, and I'd be one of them, who are aggressively looking and aggressively working to try to find solutions. Senator Garland Gudger, you're fortunate, he's your senator, he represents you here. President Pro Tem, last year he created a group, the Rural Roadmap. Within the Rural Roadmap, there are several different buckets that is being examined, one of which is healthcare, and I was grateful and fortunate that he asked me to serve on that. There's a lot of thought processes going on to try to figure out what we need to do. What I do know is we can't keep doing everything the same as we always have because it's failing. It's failing because we don't have enough resources. It's failing because we don't get paid sufficiently for what we do. Now, that doesn't mean that the hospitals are going to close or should close. I don't have all the answers, and I don't propose to do that, but we are looking at things differently. What do we need to do? How do we need to approach the healthcare delivery system in the state of Alabama? Because there's nothing that healthcare doesn't touch. When you talk about infrastructure, you have to put healthcare in the middle of that. And that is part of what our messaging in the city told you so. That's part of what we're trying to reinforce. We are infrastructure. You don't have economic development without access to healthcare. When economic developers come into an area, they ask two questions. What does the education system look like in that area, and what healthcare do they have? Those are the two things. I've spoken to a lot of economic development groups, and those are the two things they care about. They don't want to know you have an urgent care center and that's enough. They want to know that you have a hospital. They want to know that you have access to treatment that their workers may need. That doesn't mean that every rural hospital should do everything that there is. Every hospital can't and shouldn't. The higher tertiary care hospitals, that's what they're there for. Our responsibility in rural hospitals is to do what we can within the resources that we have to treat or to stabilize and transfer. That's critically important. I have stories and stories and stories after 30 years of things that would be the reason I'm standing here today and why I'm so passionate about rural health care. Not only because I'm a rural girl and my parents still live in rural Alabama and I have family that still lives in rural Alabama, but because I represent really good people who are trying to do the right thing, but we need a little help. Your voice will be important in all things, and I'm always available. I share my cell phone number after COVID. It's not a secret anymore. I share my cell phone. I share my email address, anything you want. I'm happy to address and answer any questions that you may have. The cost of health care rising, that's health insurance. I'm going to end with this. Aren't you glad? Right at the tail end of COVID, when people were starting to feel a little bit safer being together again, the Alabama legislature, both a joint caucus meeting, both the Democrats and the Republicans invited me to come. Obviously, hospitals were tip of the spear during COVID. My job was pretty much being the liaison between the Alabama Health Department and every hospital in the state on deploying resources and facilitating patient care and transfers. It was a very challenging time of life for everybody. So they invited me to come and kind of give a state of the state and what's going on. And at that time, some of the COVID relief money was starting to be discussed and it was going to be allocated, and they really wanted to hear what was going on with our hospitals and what financial resources and what staffing problems we were having, just basically state of the state. And so I did. I went and I spoke to them, and I had a question from one of our representatives, raised his hand and asked me the following question. If I owned a hotel, and that hotel was completely full, and I had no rooms to spare, and I didn't have room for anybody else to come in, I'm going to make money. My capacity, I'm full, I'm making money. I don't understand why you're telling us that you are over capacity in hospitals, you have more patients than you have room for, but you're losing money. And I had to think for a few minutes to understand the disconnect between thought processes of businesses and healthcare, which are totally different when you had to look at the way things happen. My only question to him publicly, and then we met privately to have a longer discussion, was, does everyone that walks into your hotel have the ability to pay? And if they don't, do you still have to give them a room? And does everybody that walks into your hotel that's hungry, that can't afford to pay, do you still give them a room and something to eat? And do you charge the exact same thing for every hotel room that you have, or do you have different levels? Because we can't do any of those things. It's very different. The cost of providing care, the charges that you see on your bill, and the reimbursement for what we get paid have nothing to do with each other. It's not any other free market model that there is. There's no business model. It doesn't make sense. We don't have control over our own charges, and we don't have control over our own prices or our reimbursement, obviously. It's very difficult and it's very complicated, and I'm not trying to sound like woe is us, but I think it's important when people understand the complexities of it. It's not as easy as it looks. It's not as simple as it looks. And again, you have a gym in your hospital, you have a gym in your leadership. We have strong legislative support. We have excellent congressional support. We're working hard every day. And again, I'll answer any questions if you have them. I'm always happy to talk. I'm always happy to explain or to discuss anything. But thank you for being here. You are proof of how important the healthcare system is in your community, and I thank you.
Thank you, Dane. And just, Taylor, just go back one slide, I'm sorry. So some of the numbers that Dane was talking about, when you think about Lakeland Community Hospital, that economic impact of $41.4 million is not the salaries of our employees. It is everything that we touch, from the vendor to the lawn care person to the food that is bought to the dollars that is spent by our employees and the businesses locally. We also have almost $1 million of uncompensated care, and that's the monies that, and the people who come to our hospital who are not able to pay, and we take care of those through our financial assistance programs. So we're going to now talk about some numbers and protecting our community's future. So this slide is dedicated to what happens if your hospital closes. Winston County becomes a healthcare desert. Dane talked about that for a minute. Look that up and see what that means. And you may think, Sherry, there's a lot of people in here that have clinics, and we have physicians and providers, and you're absolutely right. But when you become a healthcare desert, your community changes. The environment changes greatly, from grants that you receive, from the way you're categorized within the healthcare system. That is not a place that you want to be, as there are several now in South Alabama. The population declines. Wes has statistics, Toby has statistics. Toby's going to talk about that from his Mississippi standpoint. Every time a hospital closes, the population declines. And there's a lot of reasons for that, but people choose to live in different places. Businesses choose not to come into your community. The next, important to those of us who have aging parents or aging ourselves, admissions. When you need to admit a patient, or when your family member needs to be admitted to a hospital, and that's something we can care for, you get to stay home at night, right? You get to go home to bed and you talk to that nurse and they say, I've got him, I've got her, I'll take good care of her or him. And you get to go home. If you have to go to Florence, Huntsville, Birmingham, you've got to have a hotel room. You're going to have to take off work. All of those things happen when you start taking care of your family and they have to go out of town. And sometimes that happens anyway, right? We don't offer a lot of services that you may need to go out of town for. Open heart surgery, brain surgery, those type of things. Where is the community going to find similar businesses with similar wages to replace that economic impact? Where are you as county and city leaders going to find a business for 200 employees who can come in at an average hourly rate that you make as an x-ray technician, as a nurse, and bring that in without spending a lot of money to get them here? That's an expensive investment that you already have here. So for us, a path is important. I would never ask a community, I would never ask city officials and county officials to invest in something as a business owner myself that doesn't have a good impact in the future. So a successful critical access transition and financial stability is our path to success. We do not want to continue a failing business. We do not want to continue to have a business here in town. And I'm saying business because we all know it's implied we take care of people. but the economy that a hospital brings to this community, that this hospital brings to this community, is vital. And what we need to do to protect it, preserve it, and ensure that it can stand on its own is very, very important. So with that, I'm going to turn it over to Wes. Wes is going to talk about the financials of the hospital, and then he's going to turn it over to Toby, who's going to then tell you about the work he's doing in his space.
Thank you, Sherry. I think I know most of the people just like Sherry here. I was not born in Hale, but I was raised here. Went to high school here. Both of my in-laws are still here. So I have a great passion for this community. I actually served at this hospital previously. I was here as the CFO and the CEO from 1998 to 2006. So I've been back for about a year. And it's a much different story then than it is now. We talked about some of the numbers. Dane talked about, kind of those volumes about if your hospital is full. Well, back in the day when we were here before, Sherry and I both left about the same time. And I'll kind of compare some of these numbers here. Our annual average daily census for the inpatients in the hospital was about 27. We had 49 beds that we were licensed for, so 27 beds. So there would be times in the wintertime where Dr. Ray would say, hey, I'm an inpatient. We'd say, that's great. Who do you want to send home? Because we don't have any more beds. So that wasn't that way year round, so we averaged about 27. Today, that number is somewhere around 7. And there's multiple reasons for that. We used to have surgical services that we do not have that would have led to some admissions. During COVID, we closed our intensive care unit, so there were patients that might need a higher level of care that at that point in time we would have admitted to the hospital in case they needed that ICU care. And now sometimes we have to transfer those patients someplace else. So there's a lot of factors as to how we got where we are. At that point in time, our EBITDA as a hospital was around $5 million positive. And you can see that now, so this number here, EBITDA means the earnings before interest, depreciation, and taxes. This is the nerdy portion of the program. So you can see in 2023, that number was a $3.7 million loss. So this was about the time that I think Sherry came back onto the Healthcare Authority Board. So we've made a lot of progress in the last 2 years. So this part is kind of in the state of our healthcare. There's a past, and there's a present, and then we're looking to the future. So you can see in 2024, we reduced that by over $500,000, and again in 2025, we reduced it by another $500,000. But we're still at a total operating loss of about $2.5 million. Now, when you come down to the net income line, you see that we also do get support. So that line that's in there that says other income is the support that we get from the taxes from the city and the county. We're very appreciative of that. They're not completely adequate to get us to a positive bottom line, though. As you can see this net income number here, even with this support, we were at about a $2.2 million loss in 23 and a 1.7. We've been able to get that down to less than $500,000, but we would still need the support to be able to get us to that number. So what we have looked for the future, we made the decision that, well, really what we need to do is we need to change our model. When you see these numbers, and Dane alluded to it, you see these numbers at the top. That top number is our gross revenue. Well, that's just what we charge. But as Dane mentioned, that is not what we get paid. We are the only industry where we do not dictate what we get paid for the services we provide. That's dictated by the insurance companies. And so you can see these deductions from revenue is what we have to adjust off. It's a contractual allowance to get us down to what our net patient revenue is. So you can see that net revenue, there has been some declines in some net patient revenue as we have looked at how do we make the hospital more profitable. Sometimes you have to peel some things off that are not profitable, as any business would. And you can see that we have some declines in our total and our net revenue, but we've also had a significant decrease in our expenses. But we've really done about all we could do from an operational standpoint to get to a positive. So if we continued on, there's really not a whole lot of fruit hanging very lowly that we could go after to try to improve that number. So the next step is we need to increase this number. We need to increase the amount of revenue that we receive. And the way that a lot of hospitals do that is by a conversion, rural hospitals, is by conversion to critical access. So there are roughly 1,800 rural hospitals in the United States. Almost 1,400 of them are now designated as a critical access hospital. So you're looking at 77%. So this is not some, flash in the pan type thing, not something that we dreamed up. This is an established program that has taken off in many more states. If you go and look at states in Mississippi and Tennessee and Kentucky, and most of them have 30 or more critical access hospitals. We are, I think, one of about 9 or 10 in Alabama. So there's just a very low, for some various reasons, of why that was not, didn't take off like it was in other states. There were some legislative things I think that was perhaps the cause of that. But that is how we are going to secure our future. So this bottom line, the very bottom lines you see, is we, as part of the critical access application process, we had to go through our Medicare cost report, which is what will now determine what we get paid, because we will get paid, instead of getting paid what Medicare, which constitutes about 2/3 of our business, by the way. Medicare and Medicare Advantage plans constitute the vast bulk of our patient volume and patient revenue. So as now they will pay us based on our reasonable costs. So it kind of makes sense logically that if here's your cost and here's your revenue, well, you're not getting paid what your costs are. So if you get paid what your costs are, then your revenue is going to go up to account for that for the largest portion of our business. So we had to do a calculation of what impact would that have. And if we had been a critical access hospital in 2023, that would have meant a almost $1.4 million increase in our bottom line, in our net revenue. That number 24 grows to almost 1.5 million and almost 1.6 million in 2025. So you can see that if we had been a critical access hospital at that time, we would have paid our total net loss. Now we would have still needed the support of our county taxes, our city taxes, but we would have been able to almost eliminate that last year, and we would actually be in a positive for 2025. Next slide. So this is just a restatement, and these are, instead of in millions, these are in thousands, because I had to shrink it down to be able to fit on this page. You can see this is just a restatement, and this is a projection going forward, and this is projecting it fairly conservatively. If we had the exact same EBITDA for this year, where would we be? Now, we factored in a couple of assumptions. We said, okay, let's say we tried to take in less money on the city and county taxes. So we actually took the average of these numbers and kind of decreased that over time and said, okay, projecting that out over 5 years, let's say we didn't have to be as reliant on those county taxes. We would still have the same amount of depreciation expense. And so this is where we would be before critical access. But then you add in the impact of the critical access on both the same store, which is what we do now, and then the new services, which are the things that we would add. Things like the IOP program. Things like there's some other services that in a critical access world we can take advantage of. And won't get into all the weeds of all of that, but there are advantages to purchasing pharmaceutical, for purchasing our drugs with a discount that we can take advantage of. So there are several things that we can do that would improve this bottom line. So there's a path going forward where we can see that at some point in time in the future, and this is what we're striving for, is that we may be able to have a point in time where we don't have to rely on any city or county support to be able to have a positive bottom line for the hospital. I know that was a lot. Anybody got any questions? I will give you just a few more since we're talking about some statistics here. And Dane alluded to a little bit of this too. Since this, turning back down a little bit, since 2010 in the United States, 182 rural hospitals have closed. In Alabama, there are 106 hospitals. 71% of them have a negative margin. She alluded to the 54 hospitals in Alabama, with 83% of them having a negative margin. And so there are, since 2010, there have been 14 hospitals in Alabama closed. So 14 out of the 182 closures is almost 8% of the total, which is over 4 times the national rate of closure. So Alabama is a very difficult place to practice. I did want to also mention in the expense lines some of the economic impact of what we provide. So in those expenses, we pay $71,000 in city occupational taxes, our employees do. We pay $22,000 in city water usage, $43,000 in gas usage, and our annual electrical usage. We pay Alabama Power. Sometimes people don't understand how much it costs to operate the hospital. We pay about $365,000. So it's about $1,000 a day in electrical usage. And the last thing that I'll mention before turning it over to Toby is one thing that Sherry mentioned, which was population. So I pulled 5 hospitals from communities in Alabama that had a population roughly the size of Lakeland that had lost their hospitals. And over the past, and this is since 2010, so those 5 hospitals, the population of their communities has decreased 11%, negative 14%, negative 12.6%, negative 13.4%, and negative 23.8%. So I'm just trying to reiterate a lot of the points that the other folks have made about the importance of this community, not just as to the healthcare, which it is, but as the economic driver and the supporting what we do for this community. I'll turn it over to Toby.
A whole lot's already been said that I won't repeat, so I'll try to hit some high points. I'm mainly prepared for a Q&A, so you'll excuse me if I bounce around a little bit. But Toby Butler with Trilogy Healthcare Solutions. Most of my career has been dedicated to improving delivery and financial sustainability of healthcare around the country. Many years in the corporate world, publicly traded healthcare world, HMA, Vanguard Health Systems, HCA, and Tenet. So I left the corporate world about 14 years ago and started Trilogy Healthcare in an effort to actually help hospitals and communities that really needed help rather than just trying to improve shareholder wealth of a very large corporation. So that's kind of why I'm here. Spent the last 14 years with Trilogy Healthcare, and 7 of those years, up to 4 years ago, was the Vice President of Community Hospitals for North Mississippi Health System. I had responsibility for their 6 outlying community hospitals, which reiterated to me, or drove home to me one point Dane made earlier about keeping healthcare local. The Tupelo campus that many times could not handle the volume of patient load that those community hospitals had if they did not have those community hospitals. So, especially during COVID, which I had those hospitals all during that process, which was quite a challenge. Would have been completely overwhelmed without having those 6 outlying community hospitals. So, big believer in rural healthcare and the importance of rural healthcare, and I am rural. I'm a big believer in not just rural healthcare, but rural communities and rural America. It's the backbone, in my opinion, of our country, and culture, and way of life, to a large extent. From rural Jones County, which I know is redundant. Anybody's ever been to Jones County, Mississippi? Or the Free State of Jones, which, we just chose to fight everybody that destroyed our crops or stole our mule. So very rural where I grew up. We don't have a hospital there anymore. We had one when I was a baby, but we don't have one there. So 2 key components of rural healthcare to me, besides the access to healthcare, obviously, in our communities, and that's when you have chest pain at 2:30 a.m. on a Tuesday or a Saturday or Sunday, or a broke leg or whatever it might be, to know that you have access to a place to go to get the care and stabilizing care that you need as close to home as possible. And the Also, so that's the access to healthcare, but also the economic impact, which has already been mentioned a couple times. I'll mention just a couple things. I participated in a Rural Health Council for Governor Phil Bryant, Mississippi governor, two terms ago. And we were commissioned with doing a study with different things to improve sustainability and access to rural health care. And we worked with the Mississippi Hospital Association to do a study of one particular rural county, which I won't name, but it was a county of about 9,900 total population in the county. It had a rural hospital there that was in danger of closing at the time. It happens to be one that I got involved in and took over. We did a study of the entire economic impact of that hospital in that county of 9,900 people, and it was over 70% of the entire economy was impacted by that hospital and its affiliated entities and the supplies and everything else that it bought and contributed. So, in many cases, I've gone back, there's a few other studies, I don't have the details with me, but when a rural hospital closes in communities of that size, it's almost a death sentence economically for those communities. It's devastating. Rural hospitals are usually the number one, number two, or number three employer as far as number of jobs in the communities where they exist, and usually the number one, two, or three highest average wage. These are professional positions, many that require degrees, advanced degrees, and there's scarcity in many of those jobs as well. So one of the largest employers in a rural community, and some of the largest average wages in those communities as well. So just another point to speak to the economic impact of those hospitals in rural communities. And this hospital, I think, currently has around 195 employees, right, Wes? And I have not done the analysis how high that is on the average hourly wage scale compared to other industries and businesses in the community, but I'm guessing it's in the top three. So I usually ask this everywhere I go when I speak to, I mostly do a lot of advocacy and advisory services for hospital boards and boards of supervisors and whatever, different hospitals, different rural communities. And I usually ask about economic development. How many economic developments do we have in progress right now that would replace that economic impact? And usually, and hopefully the answer here is like we've got 5 or 6 in the hopper right now, ready to close, right? But it's usually not the case. It's really hard to accomplish. So just to drive home a little bit more about the economic impact of rural hospitals. And I will tell you, with this hospital, one of the first questions that was asked when I got involved with Sherry and West was about converting to critical access, which I adamantly said, yes, that is the way to go 100%. It is the most sustainable model in rural healthcare for rural hospitals. And it absolutely was the right step. It's the right model to run. So we've converted to the right model. We just have to run the right playbook. And there is a playbook through years and years of experience of doing it wrong and doing it right that works in a critical access hospital for a community of this size. And I'm very confident that you've got the right leadership team now to run that playbook. They've already started running the playbook. There's already steps in progress and in place, but it is going to take some time. There's a complete change in reimbursement model from the model that they've had historically. It's going to take 1 to 2 years for that change in reimbursement model to settle completely out. It has to go through a cost report cycle, usually about 1.5. So there's another year or two that it's going to take for all that to settle in and all that to stabilize. So it's going to take just a little more time, a little more patience, a little more support. And on the leadership piece, I will tell you this is something that came up. Just finished my last term as president of the Mississippi Rural Health Association, and one of the things I talked about in my last address was one factor that is not talked about enough. There's a litany of issues of what's causing rural hospitals to struggle, in many cases close. But one of them I don't talk about enough is the lack of experienced, qualified leadership in these rural hospitals. Extremely difficult to find. There's an extreme shortage. Doing all kinds of things in the state of Mississippi, and welcome to get involved in the state of Alabama as well, and some involvement in Arkansas and Louisiana on what can we do to start developing more healthcare leaders. It's really difficult to recruit high-quality, experienced executive leadership for rural hospitals, and it is absolutely critical for their success and survival. And why is it hard to recruit? Well, there's not a whole lot of them. There's a dramatic shortage, and there's been people leaving the industry a lot, especially since COVID. It was a pretty brutal time for hospitals, obviously. but it's hard to recruit against larger tertiary facilities and larger urban communities and metropolitan areas. Number one, it's not nearly as challenging. Rural hospitals has got to be, in my opinion, one of the most challenging aspects and elements of one of the most challenging industries, period, in healthcare and hospital business. A hospital is not like one business. It's like a conglomeration of 50 different businesses with different regulatory bodies, different challenges, different reimbursement models, everything you can think of, and you have to pull it all together, and it all has to work together harmoniously in a cost-effective way. But it is extremely challenging, so when you have young or experienced, not necessarily young, but experienced leadership, healthcare executive leadership, we're trying to recruit against Memphis and Birmingham, and Tupelo, and Jackson, and Huntsville, and all those places where they can go and have a lot easier job and probably make more money and have access to whatever is important to people, restaurants and whatever. So it's very difficult. But I will say you guys are very blessed to have a strong leadership team at this hospital here, which is one of the key ingredients that I look for. I've gotten to know Sherry pretty well in the last few months, but Wes has worked with and for me twice in the past and did a good enough job the first time to hard to do it again, so that's pretty impressive. Pretty hard to do that at that point in my career. So Wes has helped turn around a couple of really challenging hospitals that I've been involved with in the past, including one in North Mississippi. I gave one quick little comparative. This is recent. We talked a lot about this. It was a hospital, a critical access hospital in Ackerman, Mississippi. It's Choctaw Regional Hospital. Got involved in that hospital June 1st of 2014. It was slated to close the doors permanently on July 1st of 2014. They had one doctor and one nurse practitioner on medical staff, and within 60 days I terminated the contract of both of them, and about got strung up on Main Street for doing so. Everybody freaked out. We had 2 doctors already lined up to take over and cover. And today we have 13 doctors on medical staff. We have over 200 employees and have a $10 million cash surplus at that hospital in Akron, Mississippi, which the county and city has a substantially smaller population than this county and city. There's more examples like that. Pontotoc, Mississippi is another critical access hospital. It's part of North Mississippi. There's many others, but that's one recent that's relatively close by that was worth mentioning. It can be done, and I believe it will be done in this community. We are on the right track, we're in the right place. There'll be a little bit more patience, a little more persistence, and a little more, we just need the community to continue to support it. So I'm going to close by restating that the hospital has converted to the right model for sustainability. It's already running the right playbook, it's on the right path. It is going to take a little time, it's going to need continued support. With the continued support of the community, you absolutely can and will have a sustainable hospital that provides access to quality health care and a vital economic engine for your community. So, thank you.
Thank you, everyone. I hope what you heard tonight is a path forward for our hospital. While I consider myself, and others consider myself, an expert in healthcare along with Wes, this is not something you can do. This journey is not to be done alone. We have Carl Riggs Ingram, we've had Forbes, we have Trilogy, we have the Alabama Hospital Association, and other consultants who are either working free to help us or at a much reduced discount to ensure that we are doing all the things to have a successful path forward. So at this time, we've done all the talking. You've been very patient for about 55 minutes. We'd love to open up the floor for any questions that you may have as we've gone through a lot of information. So Dane, Tony, Wes, if you'll come up, and we'll start on this side and work our way over. So any questions? And we do need a few. I didn't prep any ahead of time. Yes, Shane?
About the tax credit, like the state, so how do you make a donation to the hospital and take that off your taxes? I heard dollar for dollar, that's what I got.
That's right. Tax breaks always
How do you do that?
Can you hear me? Can everybody hear me? I used to be a cheerleader, so I know how to emote. It is a program you go through the Alabama Revenue Department. You, as an individual, and I did it. I made a contribution to one of our hospitals, where you can go to the Alabama Revenue, and we'll send you all the information. It's too late now, but it's coming again next year.
Okay.
There's a form that you fill out. I'd like to give X amount of dollars to Lakeland Hospital. First of all, they're going to verify that Lakeland qualifies for the donation. And to qualify, they have to meet the definition of rural, which is federal, and they're on a list already that the Rural Hospital Investment Program Board and the Alabama Department of Revenue have said, yep, they qualify. I would like to give $1,000 to Lakeland. So they're gonna say, thank you for applying, hang on a minute, we're gonna let you know. Then they're gonna get back in touch with you and say, yes, they do qualify and you can do it. So at that point, the clock starts ticking. You have 60 days to get your money to the hospital. You don't have to do it right away. Then the hospital has to let the revenue department know that they received your money. Then you get a certificate from the Department of Revenue that you will use for a dollar-for-dollar credit on your income tax filing that year.
Is there a limit to the amount you can?
There's not a limit to the amount you can give. There's a limit to the amount in total. So right now, the cap in the state of Alabama is $20 million. This last year.
I won't give that.
Yeah. Welcome to.
I'm first out of
That's right.
Yeah.
And there are some people in the room today, I know the private donors did not want to be called out, but I will say that they are all in this room at this point. Bank First is one of our largest donors, thank you, Will. I know you sat down with Wes and talked through that. And Alabama Power, Scott Knight, I saw him in here. And thank you, Scott, for the donations there. We didn't get our total cap, we came close. And then this year we would even work harder. It was a lot of education that we had to do. And to be honest, some people thought it was a little fishy, you know, like, I'm gonna give you this money. But we did appreciate all the donations that Yes, so thank you for that question, and you will be hearing, we've already got some dates and times coming up after the summer to talk about that. Other questions on this side of the room? Scan the room. Questions? Questions? A couple more.
Sherry,
Yes.
workman's comp, you take a business about one name, and you don't have a hospital that's within a certain area. What's that do for workman's comp?
Yes, so the question is what happens to a business without a hospital in work comp? So I can't give you the dollar for dollar, but we do know, and Dane can even elaborate on that. Do you want to elaborate on that, Dave?
I'm sure
Okay.
I will add whatever you want.
Is that without 24/7 coverage locally, especially industries who run 24/7, it can be problematic and those numbers can increase. Also, the ability to have a physician 24/7, there are some criteria there that say, you know, it's great to have a nurse practitioner, but there's check boxes that say, do you have a doctor in your ER? And the rural hospitals have struggled with that, the rural emergency, because some of them are pushing legislation and not have a doctor, it may impact their work comp.
What radius?
I think there's a radius, like 30 miles or something.
There is a radius, or it depends on the type of business. If it's a high risk business, then that radius needs to be smaller. You know, if they are working with a lot of skilled equipment or, you know, things that you could have limb severance. And again, not taking anything from anybody, but that physician ability, that 24/7 care, you know. One thing that we have that maybe no one realizes is called CoreFab. Anybody know what CoreFab is? I hope you don't. If you get bit by a snake, you need it, a poisonous snake. That's something that we carry day in and day out for that snake bite, that you can get 24/7. Those are things that work for police. Other questions? Yes.
Is that supposed to be happening?
We're in a church and
Yeah.
it's just, things are just coming down for us. So you heard Wes and Tony talk about the path. And definitely having the critical access designation, critical access hospital designation, we have our path. But we do have to have help getting to the end of the path. And we will be asking, again, some of our legislators for that assistance. Thank you to our county commissioners for sitting down with us and talking with us in that work session to understand. And I hope this helps our city officials, our local businesses understand that we are not asking for a free, just a check without a plan. That's not good business sense, and no one should sign up for that. We have a good plan going forward for this hospital, for this community. We are community leaders, we are community owners, business owners. We care about this community. You may wonder, well, every one of us can tell you a story. Wes and I started this hospital in the 90s, and I have to tell you a story. I'm going to take credit a little bit for Patrick Lowe. Patrick Lowe came to our hospital. I sat with him in every surgery, and he looked at me, he's going to be I'm not going to quote him exactly, but it was, I'm going to be the best surgeon you've ever seen. And you know what? The man was. That's what hospitals do. They make a difference in lives. Patrick Lowe made a difference in lives all across this country because he sat down with us in a hospital and he got some experience. And those stories, I could go on and on. I'm one of those as well. So thank you tonight. If you have questions, myself, Dane, Toby, Wes, we are all up here. We would love to answer any of those. Thank y'all for this. We will have this every year as we move forward, and we appreciate your support.
Let me get a picture.